Hello, welcome to the EKG Guy and welcome to the EKG of the Week. I hope you're having a great week and I'm glad you could join us. This week's case is a 90-year-old asymptomatic female with a history of Lyme carditis that presents for an annual visit. Her presenting EKG is shown below. Now before we get started, let's review the approach we've been going through to interpret EKGs. So notice that we have the patient's clinical presentation and then the EKG below it. On the right side of the screen, we have a list that we'll go through before making our final interpretation. First, there's the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And if it's irregular, is it regularly irregular or irregularly irregular? Next, we have the heart rate, in which we simply want to determine the rate of the rhythm. Then we have the rhythm origin, that is where in the heart is the rhythm actually originating from. Then we have to determine the ventricular or Qrs Access, which will help us with our differential diagnosis. And then is there atrial, atrioventricular, and intraventricular conduction delays. Okay, so we're looking, are there any normal or abnormal conduction areas within the heart? Then we have the waveforms, which would include all the waves, segments, and intervals. And lastly, anything else, meaning is there anything else that we've missed or still need to mention, such as abnormal R-wave progression or a transitional zone in the precordial leads. After that, we'll use all this information that we've gathered to make our final interpretation of the EKG. Now I want you to pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll walk through it together. Alright, so our 90-year-old asymptomatic female with a history of Lyme carditis presents for an annual visit in this EKG. So let's go through it. First, what is the regularity of this rhythm? Well, on first impression of the EKG, you probably notice that the rhythm appears quite regular, and that is correct. This is a regular rhythm, okay? So what we have here is a regular rhythm, okay? And how do we know that? Well, one of the easiest ways is to look for those tall R waves, okay? Oftentimes you can see that because the Qrs Complex represents ventricular depolarization, and the ventricles make up a lot of the conduction impulse that we see on the EKG, okay, because of their size. So if you look for the R wave, which would be here, this is an R wave, which is the first positive deflection after a P wave. Here's the next R wave, okay? So from R wave to R wave, we call that the R to R interval. And for it to be a regular rhythm, we want to have constant R to R intervals throughout, okay? That would mean from the next R wave, so this R wave to the next one, should have the same distance between it, okay? And then the ones that follow, all right? All the way throughout, okay? So these R to R intervals are the same throughout, and that's what we mean by having a regular rhythm, okay? And if you were to measure these all out, you would see that all of these R to R intervals are the same, okay? So we have a regular rhythm. All right, so next we have the heart rate. Well, this is a regular rhythm, so there's a couple ways we can find the rate here. Now, one would be to simply count the number of ventricular complexes going across the EKG and then multiplying it by 6, because we know that we're working with a 12-lead standard EKG, which represents 10 seconds, okay? So let's just erase this to clear it up. Okay, so now we're going to look at the rate. Specifically, we're going to look at the ventricular rate, okay? Meaning we're going to look at the ventricular complexes and get the rate here. So we know that we have a regular rhythm. We know that the standard EKG represents 10 seconds. So if you multiply 10 seconds by 6, you get 60 seconds, which is 1 minute, okay? Meaning that if you count the ventricular complexes going across, multiply that by 6, you can get an estimate of the rate in beats per minute. So let's do that. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, okay? So what we would do now is 9 times 6, okay, to get us into that beats per minute, or 1 minute, and that gives us 54 beats per minute, okay? Now, we said this is a regular rhythm, so there's another way we can do this, okay, and find the rate. So we erase this here to clear it up. Okay, and the other way is by finding a Qrs complex, one of those R waves that falls on a thick line, and then counting the number of thick boxes between that of the next R wave. So if you see this complex here, notice that this R wave falls right on one of these thick lines. The next R wave is this one. Here's the Qrs complex. This is our R wave here. So notice it's just beyond this next complex there, or next thick line. So if we count the number of thick lines between them, we have 1, 2, 3, 4, 5. Okay, so it's just over 5. So remember, 300 over 5 is 60 beats per minute, and it's a little greater than 5, so we will say that it's slightly less than 60 beats per minute. Okay, so slightly less than 60 beats per minute, but close to that. And the actual rate on the EKG machine measured 57 beats per minute. Okay, so you can see that we were quite close. 57 was the actual ventricular rate here. All right, so we'll erase this. Okay, and next we're going to move on to the rhythm origin. So notice that we have narrow Qrs complexes, so we must be dealing with some supraventricular rhythm, okay? That is one originating from above the ventricles. We can also make out clear, defined, similar shaped P waves in each lead. So we have to ask ourselves, are we dealing with sinus rhythm? Okay, so let's see here. Do we have sinus rhythm? Okay, so remember, when we look at sinus rhythm, if we draw our box diagram of our heart, this being our right atrium, this is our left atrium, this is our right ventricle and left ventricle. Remember, our sinus node sits up here in our right atrium, okay? And then we have these internodal pathways that come to an AV node. And from our AV node, we have a His bundle that splits off into a right bundle branch that innervates the right ventricle, and a left bundle branch that has a left anterior and left posterior fascicle that innervate the left ventricle. Now these bundle branches on the right side and then the fascicles on the left side then go to the ventricular Purkinje fibers that innervate the individual cardiomyocytes, and that's how the impulse spreads. Okay, so what we say here is when we look at sinus rhythm, we want the rhythm to originate from this SA or sinal atrial node, and notice that it heads in this direction to that AV node. Okay, you also have that Bachmann bundle coming to the left side, but in general, the main depolarization pathway is heading in this way. So if you were to superimpose the right atrium on this, okay, so imagine this is our right atrium, meaning we're taking this right here and we are placing it over this, okay, that would mean that our sinus node, if it's this here, will be placed there, okay, and you have our internodal pathways that are coming, and imagine our AV nodes there. So our conduction pathway is going to be heading in this direction, okay, so in that direction, and the normal P wave axis, which represents atrial depolarization, okay, so everything up here above the ventricles, if it's heading in this direction, normally it should be between 0 degrees and positive 75 degrees, okay? So within somewhere in this region here is that normal P wave axis, okay? And that's because the sinus node the impulse is heading in that direction, the main complex or main axis of that P wave, okay? So meaning when we look for sinus rhythm, we are going to look at leads. Lead 1 that sits here at 0 degrees, the positive end. Okay, we have lead AVF sitting down here at 90 degrees. Okay, positive 90 degrees. And then we have lead 2 sitting at positive 60 degrees. In the horizontal plane, we have V4, V5, and V6. Okay, the left lateral leads. And then we have AVR that sits here where the impulse is moving away from, which means that we could expect negative waves because the impulse is moving away from AVR. Okay, so let's look at our leads now. So if we look at 1, okay, so here's lead 1, you can slightly make out the P wave there, okay. It's hard to make out the other ones. Here's lead 2, it's a little easier, there's some P waves, okay. And then we have lead AVF. Here's an upright P wave and another one there. And then if we look at those left lateral leads, well, V4, there's a lot going on here that we'll talk about later, and same thing in V5. V5, you might be able to make out this P wave maybe here, but may not be actually. But V6 is a lot more clear. You can see a P wave there and one slightly showing up there. We mentioned in AVR, as the impulse moves away from AVR, we should see a negatively deflected P wave. Okay, here's AVR. And there's our negative P wave, and we have another one showing up there, okay? So we're getting there. Now, a few other criteria for sinus rhythm is that we want these P waves to have similar morphology, okay? So if you look here at lead 2 in the rhythm strip, you'll notice that all these P waves throughout have similar morphology, okay? And the other thing is that we want these P waves to be preceding every Qrs complex, okay? And there should be a 1-to-1 ratio where you have one P wave for every Qrs complex, okay? So here's one P wave, and then we have our Qrs complex, P wave, Qrs complex, P wave, okay? So we have a regular rhythm, one P wave for every Qrs complex throughout, okay? They all have that similar morphology. They're upright in the leads that we expect them to be, these ones here, and inverted in AVR. So we are in fact dealing with sinus rhythm. So our sinus or rhythm origin is from that sinus node or sinal atrial node. Okay, so let's now look at the ventricular or Qrs access. Okay, and you should have gotten a normal ventricular access. The actual value here is -2 degrees. Okay, so it's physiologic leftward axis shift, but still within normal limits. So we call this a normal access, and it's about -2 degrees. Okay, so let's go over how we find the ventricular or Qrs access. Okay, we'll erase this to clear things up. All right, so the ventricular axis, some of the main leads we're going to look at are specifically leads 1 and AVF, and we can also look at lead 2 if we need to differentiate between it being a pathologic leftward shift or a physiologic leftward shift. Okay, so let's look at this now. Okay, so remember, this is where 0 degree sits, positive 90 degrees, plus or minus 180 degrees. Okay, negative 90 degrees. Remember, we mentioned that lead 1 sits here, that's positive end. Lead AVF at 90 degrees, that positive end. Okay, then we had lead 2 sitting about here at positive 60 degrees. Okay, so what we want to have, and remember the normal ventricular axis, we talked about the P wave axis earlier between 0 and positive 75 degrees. The normal Qrs axis is between -30 degrees, which is about here, to about positive 105 degrees or positive 110. Within this whole range here is considered normal access. Okay, this area to the right of it, this is what we call rightward axis deviation. This would be leftward axis deviation and more pathologic. This area here would be more that physiologic that we'll talk about. And then this is more extreme axis deviation, okay, or northwest axis or no man's land you may have heard of. Okay, but what we want to look at here are leads 1 and AVF, and there's multiple ways you can find the axis. This is a simple way that people find easy. So we'll look at lead 1. Notice we're looking at our Qrs complexes, and notice that they're upright and positive, mostly positive. That means we're heading towards the positive end of this lead 1. Okay, if we look at lead AVF now, so here's lead AVF. These are our Qrs complexes, okay? You can see that it's still slightly more negative, okay? Meaning that when we measure these complexes, we're looking at the positive portion versus the negative portion. And you can see that this negative portion is slightly more, okay? And I'll erase that so you can see that again, okay? That negative portion here is slightly greater. So this is mostly negative in AVF. That means we're going away from AVF. Here's the positive end of AVF. We're going in this direction, okay? That means our axis lies somewhere in this region, okay? Because of that, we have to figure out, are we in this region here, okay? Where is that pathologic, a leftward shift, or are we in this region here? Now, we've already said that we're in that -2 degrees, which means that the axis should lie somewhere here, around -2 degrees, which would be normal. But let's see why that's the case, okay? So we have to use another lead, and that additional lead that we use is lead 2, okay? Lead 2, we said, sits here at positive 60 degrees, and if you were to take a perpendicular line to that positive 60 degrees, you would see that it runs through this region here, okay? See how it goes right to that -30 degrees, meaning that if lead 2 is positive, that means we're going to be on the positive end of this lead. It would be over here within that normal limit, okay? If it's negative, it'll be on this end, and it'll be more in that leftward shift, okay? So we'll look at lead 2. Here's lead 2. Notice that it's positive and upright, which puts us in this region here, okay? And it should make sense that we are closer to 0 because these are very positive complexes in lead 2, okay? But regardless, we're dealing with a normal axis, okay, that is at -2 degrees measured by the EKG machine. Okay, so hopefully that makes sense. All right, and next we want to look at the atrial conduction. Okay, so what did you get for atrial conduction here? Well, typically we look at leads 2 and V1 for the P wave or atrial abnormalities, as they appear to be the most evident in these leads. Okay, we saw in lead 2 we can make out those P waves quite clearly. Well, in leads 2 and V1 here we don't reach the P wave amplitude for right or left atrial enlargement, and the total duration of the P waves in leads 2 and V1 appear to be within normal limits, which is less than 120 milliseconds or 3 small boxes. So if you look here, remember we look at lead 2. Okay, so just erase this here. Lead 2 is here, and then lead V1, and we're looking at these P waves here. Okay, and these are all normal P waves with no significant amplitude changes or increase in duration. So what we would say here is for atrial conduction that it's normal. Okay. Now, how about atrial ventricular or AV conduction? Well, in this case, we are looking for any conduction delays as the impulse travels between the atria and the ventricles. Because the majority of the PR interval represents AV nodal conduction, that's where we tend to look. Now, normal PR interval in adults, which we're dealing with, our patient here is 90 years old, okay, so clearly an adult. So the normal PR interval is between 120 and 200 milliseconds, or 3 to 5 small boxes. Now, in this case, it appears that the PR interval is just at the upper limits of normal and possibly prolonged. In fact, it was measured here by the EKG machine to be 202 milliseconds, so just slightly prolonged. So we do, in fact, have a prolonged PR interval. So AV conduction is prolonged. The PR interval was 202 milliseconds, so above that 200 millisecond range. And if you look here, remember when we talk about the PR interval, imagine this is our P wave, our Qrs complex, and this is our T wave, okay? And we're looking at the PR interval. That means from the beginning of the P wave to the beginning of our Qrs complex is our PR interval. Normal between 120 to 200 milliseconds, and we said this one is slightly prolonged, okay? And you can see that here. Here's one you can look at. So this is that P wave, and this is our Qrs complex. So if I just erase that again, you can see that the PR interval is taking up a full box. Remember, one of those from one thick line to the next thick line, that measures 200 milliseconds. So just beyond that, so we have slight prolongation or prolonged PR interval and little prolonged AV nodal conduction here, okay? Next, we have intraventricular or IV conduction, and here we look at the duration of the Qrs complex. Normal Qrs duration is often between 70 and 110 milliseconds, or about 2 to 3 small boxes. Now, some consider it to be the upper limit to be 120 milliseconds, okay? But anyways, the main thing here we're looking for is intraventricular conduction and whether or not the Qrs interval is prolonged, okay? On this EKG, we can see that we have narrow Qrs complexes that appear within normal limits. In fact, the Qrs duration here is 76 milliseconds. So that helps to confirm to us that IV conduction is normal, okay? So let's just confirm that you know what we're talking about. So the Qrs intervals from the beginning of our Qrs complex to the end of it, okay? And we said that it should be less than 120 milliseconds, okay? And it's clearly the case here. So we have normal intraventricular conduction, and it was actually 76 milliseconds, okay? So clearly within normal limits. Now, how about the waveforms? Well, we already discussed the P waves, okay? There are no abnormal Q waves or Qs complexes that would represent maybe a prior infarct. There are normal T waves that are asymmetric with a slow upstroke and a steeper downslope. The PR segment does not appear to be significantly elevated or depressed anywhere. Now, the PR interval we mentioned before was slightly prolonged. The ST segment does not seem significantly depressed or elevated throughout the EKG. The Qrs interval, we said earlier, was normal limits, okay? That's what we said was at 76 milliseconds. The Qrs amplitude does not seem abnormally increased or decreased. And lastly, with the waveforms, the QTC interval is within normal limits here. And it was calculated to be 408 milliseconds. Remember, normal QTC interval in males is less than 440 milliseconds, and in females less than 460 milliseconds. So overall, there are no new major waveform abnormalities present that we didn't mention previously, okay? So no new ones, and we'll move on next to anything else, meaning is there anything else that we're missing here? Well, how about the R wave progression in the precordial leads? Okay, so precordial leads are from these leads over here. Leads V1 through V6 are the chest or precordial leads. Normal R wave amplitude should progressively increase from leads V1 through V5 as we move from right to left across the precordium. In this case, it does seem that the R wave progression in the precordial leads is quite normal, okay, and not really a major concern to us, okay. So what we're looking at are these R waves. Okay, you can see them here that it slightly increases, maybe not so much when we get to V4, but then clearly in V5 it does, okay? And again, we'll say later that this is quite a imperfect science, so in general we would say this is pretty normal R wave progression here, okay? Now, how about the transitional zone in the precordial leads? Well, this, it seems to occur between leads V4 and V5. Here's V4 and V5, okay? And the transitional zone is simply the precordial lead where the QRS transitions from being mostly negative to mostly positive, with the actual transition area to be where the Qrs complex is isoelectric. Normally, the transition occurs between leads V3 and V4. If it occurs earlier than V3, we call this a counterclockwise rotation or early transition. And if it occurs after lead V4, we call it a clockwise or rotation or a late transition. Therefore, because the transition occurs between V4 and V5, we call this a clockwise rotation or a late transition, okay? So clockwise rotation, which is also considered a late transition, okay? And it's occurring between V4 and V5. So let's just take a look at what we mean by that, and we'll erase this so it's clear. So we're looking at the precordial leads, okay? And we're saying that the transition occurs when we go from mostly negative to mostly positive. Here's V1, mostly negative. V2, the complexes here are mostly negative. V3, the same thing. V4, again, this is mostly negative complexes. And then when we get to V5, you can clearly see that this is mostly positive, okay? So we're going from mostly negative to mostly positive between V4 and V5. So our transition occurs somewhere between there because we don't have a perfect isoelectric QRS complex, okay? So we call this a clockwise rotation or late transition. And again, one thing to keep in mind for R wave progression as well as for transitional zone in the precordial leads is that it's highly dependent on lead placement, which makes this an imperfect science. So there's one last point to mention here, and you probably notice in leads V4 and V5, and we hinted to it earlier, that there's some irregular, almost waveforms that are not present in other leads. You can also see this throughout the rhythm strip at the bottom of lead V5. If you look at that lead, you will notice that this is not found in any other leads above it. Okay, so there's no temporal relationship, and therefore this clues you in that this is in fact artifact and considered poor data quality to us. Okay, so what we're talking about, and just so we can erase this here, is that if you look at leads V4 and V5, okay, notice that we have some of these squiggly lines here, okay, all these throughout, and then you don't see it in V6 or any other leads. But if you look down here at V5, you can see that same stuff down here in these leads that are not truly any waves, okay, because if you look above them, everything above it happens at the same time and it all looks normal, okay, you don't see those same changes. So that's artifact that we're seeing here, and it represents poor quality data, okay? So just one thing that you'd want to note when you make the final interpretation, okay? So anyways, let's make our final interpretation. Well, we have a regular rhythm with sinus origin and a rate that we mentioned at 57 beats per minute. The Qrs Access we said was normal at -2 degrees. Atrial and intraventricular conduction were normal, although AV conduction we said was slightly prolonged at 202 milliseconds. Now, because the PR interval is prolonged without any dropped beats, we consider this first degree AV block. And it wouldn't be too surprising for the patient's conduction defect to have resulted from when she developed Lyme carditis. Remember, she presented with a history of Lyme carditis because Lyme disease can actually affect that AV node, and we can see these conduction defects, and it can actually even lead to complete heart block if it's left untreated. There are obviously a number of other causes and medications that can cause AV block, but with our limited history, Lyme carditis in this patient is certainly on that list. And lastly, we mentioned the poor quality data in some of those leads that we saw. And now when we compare this EKG to a previous one, there's actually no significant changes. And it's always important to look back and then compare the most recent ECG, so the one that you have, with a previous one to look for any new changes, okay? So let's write our final interpretation here. We'll clear this up. Okay, so our final interpretation, we said we have sinus rhythm Okay, so we have sinus rhythm, but it's slow, so we call that a sinus bradycardia. Okay, it's less than 60 beats per minute, right? 57. And then we also have with first degree AV block. And we also want to note that poor quality data present here, okay? And the poor quality data is just a mention of that artifact that we saw, okay? And the other thing is, when we compare it to the previous EKG, there were no significant changes that we saw, okay? So in conclusion, our 90-year-old asymptomatic female with a history of Lyme carditis that presents to her annual visit has an EKG showing sinus bradycardia with first-degree AV block and some poor quality data we saw. Well, that's the end of this week's EKG of the Week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you can help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 150,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. If you need a crash course on EKGs, we launched our new EKG course. Check the link below if you're interested. The original cost is around $150, and I believe I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from the beginner level to a physician level. I've even included our pediatric lectures. Anyways, check it out for yourself. I think you'll really enjoy it, and a number of medical schools and hospitals are beginning to use it. If you are a part of an institution, please contact us because we're giving a limited number of schools and hospitals free access to provide feedback and improve our course. And in that case, you can get the course for free. So leave a comment below and get in touch with us. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you can find more lessons and practice. That is www.ekg.md. Last but certainly not least, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.